the Egyptian Vitreous Retina Society welcomes you to our new program, EGVRS Around the Retina World in 30 days. During this month, we will roam Mother Earth, traveling across the globe, visiting different countries in different continents, meeting dear friends, elite and distinguished retina surgeons and retina doctors, not just to exchange experience and to learn from each other in retina, but also in life, in culture, and to know a little bit more about the history and maybe a little bit about the famous food and cuisine in each country. Today, we are traveling a long way from Cairo, Egypt, all the way to South America, or Latin America, to a very exciting country, Bolivia. And we will meet a very dear friend, Dr. Marcelo Morello Sasamutu. And I'm just going to give a brief introduction, and then we will have a nice conversation with Marcelo. Dr. Marcelo Morello Sasamutu is the president of the Bolivian Retina Society, and he's the head of Pediatric and Adult Retina Service, Private Institute of Ophthalmology, La Paz, Bolivia. And he's a subspecialist of retina, vitreous, and anterior segment as well in the Central Military Hospital in Mexico. Just for everybody to know the location of Bolivia, maybe many of us in the Middle East are not well oriented about South America. Bolivia actually is in the heart of South America. As you can see, it's right in the center of South America, a little bit to the west, and it has common borders with Brazil, Peru, Paraguay, Argentina, and Chile. Interestingly enough, Bolivia has two capitals, La Paz and Sucre, and La Paz, from which Dr. Morello is talking to us right now, is in one of the highest points in the world, one of the highest cities in the world, at an altitude more than 3,000 meters above sea level, on an altiplano, an extensive highland plateau in the Andes region. So it's a quite high altitude. Just an interesting point, Dr. Marcelo, is that we have a very famous square in downtown Cairo, and it's called Simon Bolivar Square. Maybe many Cairns or Egyptians that go around the square don't know the history of this man. And he's originally a Venezuelan leader, and he is called the Liberator or El Libertador. And he was born in 1783 and died in 1830. And history says that Bolivia was named after his name. So he played a central role in South American independence movement initially. And we have his statue in downtown Cairo. And the Simon Bolivar Square was opened in 1979 in Garden City in Cairo, very close to the Nile River. So maybe each time you pass, you now know the history of this statue. So Marcelo, welcome to this program, and thank you for accepting to participate in this program. Anything you want to say?
Well, first, thank you for the invitation to the Egyptian Vitreous Retina Society. I think we're going to copy this in our society. It's a very interesting form to know each other and each other countries. So if you want, I can start my presentation.
Okay.
So as Dr. Sharif mentioned, I am a retina specialist living in La Paz, Bolivia. About my city, and I want to talk about a little bit about my city. So my hometown is La Paz, Bolivia. As you mentioned, La Paz is the highest capital city in the world. So the visit will literally take your breath away. Although La Paz that doesn't have a reputation for being a must-visit place, I think it's a worth exploring city in South America. So I'm going to show you some of the particularities of my city. First of all, the air, the air is in La Paz is so thin that probably your lungs won't at first have a clue what's going on. Uh, that's why it's necessary to take the sightseeing in La Paz slowly. As you can see, we have this cable car travel, so it's very common in our city, and we usually for local people, especially those who are living in poor outskirts of the city, well, are able, thanks to the cable car, to travel to the center of the city or the places located in the valley much efficiently. So that's the cable car. It's everywhere in the city. We have like 9 or 10 cable cars that are working all day. Let me talk to you about my typical food. Well, here in La Paz, for breakfast, we have this bread that we call marraqueta. Marraqueta is known as in Spanish as pan francés, in English as French bread. And we have other names like bread roll, and it's made with wheat, flour, and salt and water, basically. So it's for breakfast. It's one of our favorite breads. Then we have for lunch, maybe I can mention as sopa de maní, which in English is this a typical Bolivian lunch would consist of several courses, including a soup, a main course of meat, rice, and potatoes. And basically, that's our soup. Then I'm going to talk about the salteña. Salteña is probably one of the most important here in La Paz and in Bolivia dishes. No, salteña is a type of baked empanada from Bolivia. Salteñas are savory pastries filled with beef, sometimes pork, sometimes chicken, mixed in a sweet, slightly spicy sauce. So it's one of my favorites also. So I'm going to talk about this particular dish. The name is silpancho, which in Quechua is the Incas language is the name is silpancho. It's a popular Bolivian food from the city of Cochabamba, actually. And when prepared properly, this tends to be a large and fulfilling meal with a diversity of carbohydrates and fats, basically potatoes and rice. I'm going to talk about plato paceño. It's a traditional dish from La Paz. The ingredients of the dish are fried cheese, corn, boiled potato. And that's it. The last dish I will mention is the Bolivian fricassee. Bolivian fricassee is a traditional soup made with pork ribs or chicken, and chuño, which is a freeze-dried potato that we usually consume here in La Paz. That would be about my presentation about my city and the dishes that I want to mention. So I can continue with the things that I like the most, and it's surgery, basically. So what we usually do 2 times weekly is the retina surgeries. I use a OS4 platform. I use a Hackstride 3D microscope to perform all my surgeries, well, most of my surgeries. That's my special moment in the week. Well, sometimes I prepare my lectures. I like to show my surgeries. I have a YouTube channel, Instagram, and even Facebook. So I like to share with some colleagues, retina colleagues here in South America, all the questions that they probably had. And I learn a lot from them, and they probably learn from some cases, particular cases that we usually have here in my institution. So I'm going to show you some of my hobbies. One of the hobbies that I have is the Pilates and yoga. I practice 2 times weekly, and it's very good for the back pain that we retina surgeons have sometimes when you have a lot of hours sitting in the same position. Then I started to learn about golf 1.5 years. From now, I'm passionate sport. I really like it a lot. I have some colleagues that practice also, and we usually go on Fridays uh, to practice some golf. And finally, one of my passions also is the wine. I have a small wine cellar at home, and I usually like to collect wines of all around the world, and have always a discussion, small talks with some colleagues who likes also wine here in South America.
Okay, very interesting, Marcelo. Very interesting facts about La Paz and about Bolivia. Now, some questions. Now, you are living at a very high altitude. Probably you are adapted to the lower oxygen concentration. So, when you have somebody visiting from Europe or from United States, I think this high altitude is quite a problem for newcomers. So how do you help those people to adapt to such high altitude, at least in the first few days? Do you have any?
Yes, that's a very good question. It probably takes 2 days of adaptation when we recommend our visiting people that they don't need to run, they don't need to get too much movement, just walk slowly, and we give them some acetazolamine, sometimes some prednisone for the high altitude problems. But usually in 1 or 2 days, they are already set to visiting La Paz and all the places that they must go.
Because I had a similar experience because I visited Cusco in Peru
Okay.
5 years ago, and they gave me this advice. I wasn't really strict about it, and they told us not to eat heavily at night.
Right.
I had a very heavy dinner, and I had to sleep sitting all night because I didn't breathe. So I completely understand it. And even La Paz is at a higher altitude than Cusco. So do you jog, by the way? Do you run? Because I think if you go down to lower altitudes, probably you will be a great runner because you are adapted to low oxygen concentration. So
Yeah, sure. I usually not as common as I want to, but I usually try to run as much as possible. Yes, it's totally.
Okay. Just finally, we want to know, where did you go to the medical college, your residency, and your fellowship and training? Can you tell us a little bit about that?
Well, I did my medical school here in La Paz, Bolivia, at Universidad Nuestra Señora de la Paz. Then I went to Trujillo, Peru, to perform this my residency, ophthalmology residency. Then I did a short-term fellowship at DLI Center with Dr. James Tsai, and well, with Dr. Bruce Schultz also. It was like a 2-3 months period. Then I wanted to do glaucoma at the beginning, so I went to Arabin Eye Center to perform a glaucoma, to be a glaucoma specialist. But then things happened, and I wanted to do retina also. I think it's the more complete specialty in ophthalmology. So I went to Mexico and did this retina training and also anterior segment.
Are there any challenges for training for retina practice, especially surgery in Bolivia? Do you have like a fellowship program or a training program, an organized program? Because we have this difficulty even in Egypt. We don't have kind of, not like the States, you have a very standardized way of training. So do you have the same problems like we have, like in Egypt?
We have exactly the same problem. We love to prepare our some residents to be a retina specialist here in Bolivia, here in La Paz, but we have some issues here going on. I hopefully in the future, we are working on that also as a society, as the retina society, help our colleagues, our residents to perform their training retina program here in La Paz or here in Bolivia. So we are working with 2, 3 centers to try to do that. I believe in 2024, probably we're gonna see some results, but we are still waiting for that.
Great. Okay, so this is, we will end the first part of our talk. We'll have a small break and we'll come back and we'll have the scientific part with Dr. Marcelo. We'll have a small break. Don't go away. Stay tuned. So welcome back again. We welcome Marcelo again for the second part, and he will talk about an interesting topic, which is TRT, or Tetris retinectomy technique, a new approach to retinectomy. So kindly share your screen, Marcelo.
So I'm going to talk about Tetris retinectomy technique using this speed bump of OS4 platform, ORTLY platform, and the AWOS2 to perform this type of retinectomies in pediatric patients. But first, as we know, actually with this technique is one of the objectives in this description of this surgical case and these surgical techniques was actually for complex cases, retina cases with PVR covering the 180 degrees of lower retina involvement. So the purpose was to reduce the incidence of redetachment due to the complexity of this type of cases. The Tetris technique, named by me for its similarity to the structure of the blocks in the Tetris game, actually is used to change some tangential traction after post-inflammatory retinectomy. And also this multi-distribution of vectors forces helps to prevent a retinal redetachment. Basically, that's the technique and that's the objective to maintain the retina attached. So we have these techniques, the conventional technique, which is retinectomy inferior with some relaxing incision, maybe peripherally, to perform this type of surgeries. But I published this in 2021 in Highlights of Vitreoretina. It's well, actually, I did it that in 2021 to present this new technique that I think is going to be some useful for some surgeons type of retinectomy. So this TRT technique, usually we perform these blocks incisions, as I can show you here. One of the most common complications that we find performing this retinectomy is the formation of PVR, as I mentioned. Let us not forget that when we're talking about vectors, vectors are the mainly objective to, or the mainly situation in this type of redetachment. Let us not forget that vectors have 3 characteristics: magnitude, direction, and senses. Adding other variables, we have maybe some forces, gradual tissue retraction, scar tissue, formation, laser burns, silicon tamponade. All of these are some factors of retinal detachment, especially with PVR. So what we are doing here is cutting the retina as a blocks to avoid this to have a multi-vectorial traction, not in one direction, in many directions, to avoid this scar tissue. So that's one of the objectives in this paper. So the TRT technique, let me show you here. The TRT technique is a multivectorial associated with, we use intravitreal methotrexate in these cases. So to perform the retina attached. I'm going to show you a case in a pediatric patient, how this technique is performed. So this is a 10-year-old patient with all retina detachment, inferior giant dialysis, and inferior PVR. These are the pre-op pictures. We use the OS4 OR3 platform, and we use also, when we perform this retinectomy, use the SPIP form in this platform. The SPIP means it's a hybrid between peristaltic and venturi. It's a hybrid form of that the machine had, and we usually do when we are getting approach to the retina. We use this SPIP bomb in retinectomy cases, as you're going to see here. So here's the retina, the PVR, 10-year-old patient. So we first do like a semicircumferential endothermia, and then the retinectomy. Use some triamcinolone to do a very good vitrectomy and to avoid some epiretinal membrane tissue. Then when the retina is kind of mobile, we perform the retinectomy, the TRT technique, like that. No, these Tetris retinectomy blocks that are irregular, they don't need to be regular, they must be irregular and asymmetrical. Then liquid air exchange, and we use then finally the endolaser, 2-3 lines behind the blocks, and unique lines in the center of the created blocks. I use, in this case, silicone oil, and then we use a square buckle. Finally, in these cases, we use the methotrexate, 1,200 micrograms at the beginning, maybe for 2-3 weeks. Then we are changing to 400, like some papers mentioned, 400 micrograms every week or every 15 days. I followed this patient for 6 months and then I removed the silicone oil. So right now we have the retina attached, and one of many cases that the methotrexate and this TRT technique are useful in these complex cases. Thank you, sir.
Thank you, Marcelo, for this elegant surgery and this nice technique, very interesting technique, and a new name that probably many of us are not aware of it. And it's very intriguing because it reminds us of this game. Now, my question is, if you are already doing an extensive retinectomy, what is the role of a scleral buckle in that case, since you are already removing the retina? Because we usually put a buckle to support the vitreous base if there is peripheral retina. So do you think that a buckle in this case is needed, or what's your perspective? Can you just elaborate on this part?
Oh, yes, that's a very good question. Because it's a 10-year-old boy, and I prefer to have everything secure. Basically that you can avoid the screw buckle, but with a 10-year-old ball, you never know. So I prefer to put it.
Okay. And the other thing now the retinectomy, the unique characteristic of this retinectomy is that it is not a uniform retinectomy, but it is rather has radial extensions. Okay, so it's like a seesaw.
Exactly.
Is that correct?
Yes, that's correct. Yes.
And you think
as
that
much
this,
asymmetric.
yeah, and you think this pattern
Yes.
decreases the chances of recurrences or rolling of these edges? This is the rationale for doing it?
Yes, avoiding the traction of the scar tissue when it's a multivectorial, it's more easy to a new distribution of forces. So that's physics, and we can apply that to retina also.
Okay, and you routinely peel the ILM in such cases, or is an option? Like in this case, I didn't see that you did peel the ILM.
Yes.
Not necessarily.
In these cases, we as you saw, the retina was kind of flat with a PVR, so we perform OCT to see how the macular part was going on, and I didn't need to perform. Beside that, to perform a ILM peeling in a pediatric case is kind of difficult, sometimes impossible. So prefer not to do that, and prefer to do the PVR part, and that's it.
Excellent. So do you do this kind of technique only in cases of extensive PVR, like in trauma cases, or in regular PVR in detachment cases? I mean, what are your selective criteria to do this technique?
Yes, we perform some cases in 360 also, and it worked very well. I mean, the Metro68 helps a lot. I think it's there are some papers, not a lot, a few papers that mention about Metro68. We use it also in patients with retinopathy of prematurity, the advanced stages, and we have some good results. Also combine the Metro68 with triamcinolone alone to remove the scarring tissue. Sometimes is very helpful.
Excellent. Well, at the end, Marcelo, thank you so much for sharing this technique, and for sharing also information about your practice and about your beloved country, Bolivia, and your beloved city, La Paz. We are really happy, and it was a pleasure having you on board during this expedition, visiting Bolivia and visiting the president of the Bolivian Retina Society. Hopefully, we can meet in person, maybe in Cairo or maybe in La Paz. We wish you all the best.
Sure.
To you and to your family and all your team in the OR. And looking forward to see you again in more future endeavors. The AGVRS really is grateful for this contribution, and we really thank you so much.
Thank you very much, Sharif. I'm the one who is grateful. Thank you for giving me the opportunity to talk about my city and to talk about what are we doing here in La Paz, Bolivia, and South America. So maybe in the future we can meet in person here in La Paz, as you said, or in Cairo. So yes. Thank you very much for everything.
You're most welcome. And this is the main aim for this program, is to make us bond more. It's a small world. We want to know each other better, exchange ideas, exchange experience. And we learned from you a new technique and information about your country. Thank you so much, Marcelo, and looking forward to see you again. Good night, and have a good day. Bye-bye.
Thank you. Bye-bye. Take care.